Good morning, everyone. Thank you for joining us. Today, we have our session on ERAS and optimization of ERAS. And I would like to introduce our first speaker. Our first speaker is a dear friend of mine, Dr. Anu Wadhwa. Dr. Anu Wadhwa is a professor of anesthesiology and the director of faculty mentoring and advancement at the University of Texas Southwestern in Dallas. Texas. She was at the University of Louisville for 15 years and then at the University of California, San Diego, before she moved to join us in Dallas, Texas. She's the past president of the International Society of Preoperative Care of Patients with Obesity. She has been instrumental in formulating guidelines for ERAS and the bariatric surgery and HIPEC surgery and has authored the international guidelines on both of those and many other things as well related to ERAS and bariatrics. She is a member of the Outcomes Research Consortium. She has chaired and co-chaired multiple committees at the ASA, IRS, World Congress, and IFSO. The title of her session is Early Recovery After Metabolic and Bariatric Surgery, Update on Protocols and Pain Management. Please help me welcome Dr. Anu Wadhwa.
Thank you, Dr. Darwish. This is a pleasure for me to be here. I was there last year, and it was a fantastic conference. Dr. Geller, again, thank you for inviting me. Uh-oh. So just out of curiosity, how many of you practice bariatric anesthesia? A lot of you. And even if you don't, I'm sure all of you deal with either obesity or some form of ERAS protocol. So I hope you have some take-home points whether you practice bariatrics or not from this. I have no disclosures or conflict of interests. So just the concept of early recovery after surgery actually involves increasing the quality and safety to reduce complications. And it was introduced essentially from a business perspective as well as from the patient safety perspective to reduce costs, because hospitals realize the earlier they can send patients home, the better it is for for business. The immediate challenge, right now we have so much information available about ERAS that the immediate challenge is not to create new information, but really it is to improve the quality of surgical care but to integrate what we already know into practice. I just want to know how to use the laser on this. I'm sorry. Can I use the laser pointer? Oh, the mouse. Okay, gotcha. So wherever you are, the challenges can be it can come in many different ways. They can come from your staff. They can just come from the institution. They can come from cost to keep that maintenance program, or just dogma, because people want to continue to do what they want to do. So from today's lecture, one thing I want to say is that whatever point you choose or whatever point you like, because ERAS is a multifaceted program, if you take back a point from any of these situations, either from preoperative counseling, admission, intraoperative management, or recovery, if you even bring a 1% change in your practice, you are likely to get a lot more in 1 year time. So even if you get 1% better every day, you will improve overall 38 times at the end of the year. So whatever point from today's lecture you can take, I encourage you to bring a small change in your daily practice. So the ERABS guidelines were published in 2021. They were an update from 2016 guidelines. I was fortunate enough to be one of the co-authors, and there were 10 specialists with 6 surgeons, 3 anesthesiologists, and 1 nutritionist from different parts of the world. So I will highlight some of the components of ERAS protocols. This is the overall, which are divided into preoperative, intraoperative, and postoperative. So for preoperative information, bariatric surgery patients receive the most counseling compared to any other patient. I love doing bariatric surgery because there is a gap of about 6 to 12 months between the time the patient sees their surgeon to the patient comes to the operating room. Most of the surgeries, we don't have that luxury. So there's a lot of time for preoperative counseling. And these patients are unique because they undergo prehabilitation. They are given an exercise regimen and a food regimen, and they get some nutritional optimization. So they get exercise and strength training, very low-calorie diet, which essentially improves the insulin sensitivity in diabetics or reduces their resistance. And one of the major advantages of that 10% weight loss is that there's a reduction in the liver size by 90%. So it just makes it easier for the bariatric surgeons to do the procedure and visualize the stomach. So that's the biggest advantage, and there's a very strong recommendation for that. So in terms of preoperative fasting, there might be a controversy that do morbidly obese patients or patients with high BMIs, do they have slow gastric emptying? Most of the data suggests that they don't. So they should also have the same ASA guidelines, which means they should be allowed clear fluids up to 2 hours before surgery, and then a light meal up to 6 hours before surgery. With carbohydrate loading, there's a mixed picture. So as you know, with ERAS protocol, we ask our patients to take 800 mLs of high carbohydrate drink the night before and 400 ml the morning of. Patients with morbid obesity can do the same unless they are uncontrolled diabetics. If they're uncontrolled diabetics, maybe it's best to avoid that morning carbohydrate loading. So I will go through the differences, some of the differences from the 2021 guidelines. So this is the 2021 guidelines in terms of counseling. The recommendation is strong. Indications for bariatric surgery should follow the national guidelines. And prehabilitation, even though the recommendation is weak, we know by intuition that you can never go wrong by weight loss and prehabilitation. This is an interesting recommendation, smoking and alcohol suggestion. So smoking should be stopped 4 weeks before is a recommend. Alcohol is 1 to 2 years. Now, if anybody can stop alcohol for 1 to 2, it may be the bariatric surgery patient, because if they can never get the 10% weight loss, they will continue to delay their surgery for up to 1 year. But yeah, the recommendation is 1 to 2 years. And then there are very strong recommendations for that preoperative weight loss. In terms of supporting pharmacologic intervention, again, we had a lot of European colleagues, and this is a very interesting intervention. 8 milligrams of IV Decadron, 90 minutes before induction of anesthesia. And a lot of us know that IV Decadron given in an awake patient can have very uncomfortable side effects. But apparently they do it in Europe all the time. Beta blockers is a weak recommendation. Preoperative fasting, like I said, is a strong recommendation, except in diabetic patients or those with those with gastroparesis. And carbohydrate loading is right now a weak recommendation. In terms of intraoperative management, there are many different components of intraoperative management. One of them is PONV, and PONV is really important because most of the readmissions after a bariatric procedures are either because of pain or postoperative nausea and vomiting. 90% of the readmissions are because of that, which is why it's really important that we plan our nausea vomiting prophylaxis very effectively. And I have a slide coming up about PONV a little bit later as to what my recommendations are. But in terms of perioperative fluid management, remember, now the surgeons have gotten so much better that the surgery is lasting only for an hour to hour and a half. So really, there is not a lot of time for giving fluids. So the goal is zero balance in terms of fluids. I'll talk about PONV. In terms of anesthetic protocols, there are no specialized recommendations. You can use inhalational agents, you can use TIVA, whatever works for you. The main thing is that your pain relief should be opioid sparing. Your analgesic protocol should be. That is the main and strongest recommendation about anesthetic protocols, and we will go into a little bit of detail in that too. So with bariatric surgery, these patients are really unique that because despite treatment, PONV occurs in about 78% women and 26% men within the first 24 hours after surgery. And there is more younger women, which is why there is a higher risk. Almost 34% have severe PONV in the first 24 hours. And even though you're giving non-narcotic or opioid-free analgesia, still about 32% patients require a rescue antiemetic. The risk was 82% with optimal prophylaxis. Optimal means if you are calculating the APFIL risk score, and if the APFIL risk score is 2, you're giving 2 antiemetics. If the risk score is 3, you're giving 3 antiemetics, and so on. And people were giving up to 4 or 5 antiemetics. So when you give optimal prophylaxis, the risk was still 82%. When you give 34, but when you give supra-optimal, hold on, let me go back. When you give supra-optimal prophylaxis, which means you give one more antiemetic than the risk score. So for 2 APFIL risk score of 2, you're giving 3 antiemetics. Still about 34% patients had PONV. So despite a triple prophylaxis, 43% of patients needed rescue in the first 24 hours. So this was my practice when I practiced bariatric surgery. Preoperatively, I gave them scopolamine patch and aprepitant. Because aprepitant is oral, it really does need to be planned adequately. Intraop, we gave Decadron, ondansetron, and a low-dose propofol infusion. And then post-op, we either gave, we had like 3 antiemetics as rescue available to them. And this kind of minimized the incidence of PONV. In terms of fluid management, because these are short surgeries, the goal is, and because they would be drinking till the morning of surgery, right? Because you are giving them that allowance to take free fluids till the morning, the goal is just to maintain zero balance. Most of these patients do not need more than half a liter or maximum 1 liter of intraop fluids. And they're needing that, and all of them are in a sitting up position, so which also minimizes some of the requirements for fluids. So maintain zero balance is a strong recommendation by ERAS guidelines. No particular recommendations. However, use of BIS monitor is recommended, and opioid-sparing anesthesia. Use of regional anesthesia will be possible, and I'll go into the details. In terms of airway management, there are several strategies about pre-oxygenation. Because it's a whole lecture by itself, I haven't really covered airway management in detail. But just to give you some salient points, it's really best to pre-oxygenate these patients in a 25-degree head-up position. It is also better to use CPAP while pre-oxygenation, which means closing the APL valve to at least 5 centimeters of water while they are pre-oxygenating to open up some of the alveoli. And if you've recognized difficult airway, it's really important to use some measures to continue that oxygenation while you're intubating, like just having nasal oxygen running while you are trying to intubate the patient. And for the really high risk, you may want to use a high flow nasal cannula while you are trying to intubate the patient, because that will really allow you a longer time or a longer apnea time before you intubate the patients. One of the other strategies that I've seen is that just inserting a nasal ray tube on the side of the mouth, so because it has an angle, it stays out of your way, and just connecting it to anesthesia circuit and running oxygen at about 6 to 10 liters per minute. So these are just some ways to passively oxygenate your patient in these very, very high-risk patients. And I just wanted to touch that, even though it's not today's topic. In terms of ventilation, important to still provide lung protective ventilation. These patients do not need 700 or 900 mLs of tidal volume. Still keep their tidal volumes at 6 to 8 mLs of ideal body weight. So not the total body weight, but ideal body weight. Minimize the increase in driving pressure. Adjust the IE ratio. Sometimes you may need to go to an IE ratio of 1:1 instead of being at 1:2, just to increase the time for inspiration, especially if you cannot oxygenate them, especially those robotic surgery patients where there are all these instruments and the diaphragm is all the way up. You may need to reduce the IE ratio. And then optimal PEEP. and recruitment maneuver that is not on the slide. So basically, after you give recruitment maneuver, which is giving a positive pressure at about 30 to 35 centimeters of water for 10 to 30 seconds. Ideal is lower time because studies have shown that if you go up to 30 seconds, you may get some micro leaks of RBC. So the best is to give it more frequently, but only for 10 seconds at a time. And then adjust your PEEP optimally anywhere between 5 to 10 centimeters of water. So these are from the publications, and we've discussed all of those except the neuromuscular blockade. So there is weak recommendation about deep neuromuscular blockade that it may improve surgical performance. And there are a couple of studies that have also shown that when you deeply relax the patients, which means that the TOF is 0 and the PTC count is 1 to 2, there might be a reduced incidence of peritoneal inflammation. You can find those studies. So there is some advantage of providing deep neuromuscular blockade. The only downside is because these are robotic procedures, there is no time, there is no suture time, right? So when they are done, now you have to fully reverse them. So most of the times, which is why the recommendation is that using Sugammadex, even though we have not in the paper, we haven't quite said it that you use only Sugammadex, but that is what we use, or everybody is to use to ensure a full recovery because there's not a lot of time to recover from that, which is why recommendation is to use that qualitative monitoring of neuromuscular blockade for these patients. I use BIS monitoring. I love using BIS monitoring for all the patients, and I have no relationship with the industry, but it allows you to use the minimal anesthetic agent possible to keep the patient deep enough. That's the only major advantage rather than avoiding awareness. In terms of surgical technique, laparoscopic procedure, use of a senior surgeon. If your center is accredited by the American College of Surgery, they are almost ensuring that you have a senior surgeon who's doing most of the procedures. And then there is a strong association between hospital volume and surgical outcomes. So that's another thing, which is why the American College of Surgery gives the accreditation for Center of Excellence for this procedure. One of the recommendations for abdominal drains is no nasogastric tubes and no abdominal drains. I think the surgeons take it pretty seriously, and we don't have much to do. We talked about the neuromuscular blockade. The recommendation, deep is weak recommendation. In terms of post-op analgesia, thromboprophylaxis, and nutrition, we'll talk about it. I'll go a little bit in detail because Dr. Geller wanted me to talk in detail about pain, but multimodal opioid-free analgesia, and whenever possible, tab block, but I'll talk about that at the end of the talk. And then post-op oxygenation, this is very important. We almost never want to see these patients laying flat. I don't like to see any of my patients laying flat in the PACU or on the floor, but especially patients with morbid obesity, they should always be sitting up for maximizing that oxygenation postoperatively. And then there's nothing wrong in giving additional oxygen to these patients in a small dose. So post-op oxygen plus a head elevated position, this is what they should be sitting like. So this is what an ideal ERAS patient should look like, sitting up and trying to drink something almost immediately 2 hours after surgery, right? For most sleeve gastrectomies, they should be able to take some form of enteral nutrition within 2 to 4 hours after surgery. And sitting up definitely would help with their FRC, residual volume, etc. We know that physiologically. In terms of CPAP doesn't have to be used as a routine. However, for patients with severe sleep apnea, and especially the obesity hypoventilation syndrome, which is the rightward spectrum of the OSA patients, they are the worst. They have high daytime CO2, they have high bicarb levels at baseline, and low oxygen levels. So that right end of the spectrum, the OHS patient should definitely go on BiPAP and CPAP. And many times I actually get the BiPAP or CPAP in the room, and I extubate them to a BiPAP machine or to a CPAP machine in the operator. But these are the ones who already have daytime hypercapnia and sleepiness. So these are the recommendations from the paper that we already talked about. And then thromboprophylaxis, they should all go on a low molecular weight heparin because of a high incidence of post-op thrombosis. So in terms of nutritional care, like I said, a liquid, clear meal should be given within 2 hours after surgery. And then all patients should have access to a comprehensive nutrition and dietary assessment. And they should all be given nutritional supplements. But that's kind of a surgical aspect. And then they also go on a long-term, almost a lifelong supplementation of vitamins and minerals. They also should all get PPI prophylaxis. And this is, as anesthesiologists, we may want to consider that we may want to give some form of H2 blockers even as early as at the beginning of the case. Whether they have any symptoms of acid reflux or not, some of these patients do develop immediate acid reflux right after surgery, and which is why we may want to consider them giving either a PPI or a H2 blocker intraoperatively. And then post-op, they also have a higher incidence of gallstones, so that's something that our surgeons take care of. So if you're practicing bariatric surgery for a while, you know that like our patients used to stay in the hospital for 5 to 6 days, and this length of stay shortened to about 1 to 2 days. And now surgeons want to send them home. They want to make them as day surgery or ambulatory surgery. So they definitely want to send them home at 23 hours. So I want to show you some data in terms of discharge for the Roux-en-Y gastric bypasses and the sleeve gastrectomies. This particular paper looked at a large number of patients, almost 9,000 and 31,000 patients undergoing surgery who were discharged on post-op day 2 versus post-op day 1. And in fact, if you see morbidity, 30-day reintervention and readmission, all of those were actually not very different between post-op day 2 and post-op day 1, both for bypasses. In fact, the morbidity was lower for patients who were able to go home on post-op day 1, and so was 30-day intervention and the readmission rate, including the ones for sleeve gastrectomies. So patients who we were able to send home early did better overall, not just immediately, but also at 30 days. So surgeons have a pretty strong point of saying, okay, I want to start sending my patients home early, and these were a pretty large number of cases. So discharge time after sleeve gastrectomies, you can see 98% of the patients were able to go home in less than 24 hours, and only a very small percentage of patients stayed more than 24 hours. Complications, mostly it was either bleeding, which was a surgical complications. I have no idea what's going on with my slides, I'm sorry. But from an anesthesia perspective, vomiting was probably the largest. About 0.6% of the patients had vomiting, which may have led to the dehydration. This is another very large study looking at all-cause mortality and the incidence of obesity-related disease. So bariatric surgery, this is a slide showing us the advantages of bariatric surgery. That bariatric surgery per se is extremely beneficial to these very high-risk patients, and it reduces the all-cause mortality substantially, including cardiovascular mortality. The diabetes, as we know, because the antrum of the stomach is resected, the diabetes disappears in less than 24 hours after a patient undergoes bariatric procedure. So in terms of ERAS in bariatric surgery, this is just a snapshot of the different components that we have talked about. Counseling, patient optimization, no prolonged fasting, carbohydrate loading, optimal fluid management. We didn't talk about normothermia, but that's one of the aspects. Using short-acting anesthetics is useful. Opioid-sparing anesthesia, minimally invasive surgery, avoiding tubes and drains, and PONV prevention. And in terms of post-op risk stratification, my slides keep moving on their own, I'm sorry. Early fluid intake, early mobilization. This is one of the very important aspects of ambulatory procedure, and then early removal of lines and drains. So to look at meta-analysis, there are about 13 published studies comparing ERAS and non-ERAS patients. So there were about total of 6,000 cases, of which 2/3 were ERAS and 1/3 were non-ERAS. Length of stay was reduced by 1.5 days with ERAS protocols, which is why I say you may take, if you are in a complicated healthcare system and you don't think you can implement every aspect of ERAS, even if you take one or two aspects, like, okay, I'm going to start giving multimodal analgesia, or I'm going to use optimal antiemetics, whatever component you have most control over, you may see some benefit. And when you have all the components, the reduction in length of stay is almost 1.5 days, which is at least $10,000 savings to the healthcare system. Adverse events were reduced substantially in the ERAS patients, and reinterventions and readmissions were also reduced substantially in these patients. So because there was a special request to talk about pain component, I don't have a lot of slides, but I will go into some detail in terms of how you can plan your multimodal analgesia, what drugs you can use. And each one of us works in a different healthcare system. So the access through the type of drugs is different. So I want to present to you what all can be used. Opioids are, of course, always available, and I wouldn't say that we should completely avoid opioids. Even people who use completely opioid-sparing anesthesia intraoperatively may need to use really small doses of postoperative opioids. So we are never saying that do not use opioids. They do have a role. But if you use effectively, like drugs like acetaminophen, norepinephrine reuptake inhibitors like tramadol, ketamine, local anesthetics that can be either in regional anesthesia or alpha-2 agonists like dexmedetomidine, asking the surgeons to block the ports of the laparoscope, and then using nonsteroidals and coxibs effectively. My protocol is, preoperatively, I give them a combination of Tylenol, 1 gram, Celebrex, 200 milligrams, pregabalin, anywhere between 50 to 150 milligrams, depending on how much pain I'm expecting. These are the 3 drugs that I give preoperatively. I may give them methocarbamol, which is a muscle relaxant, depending on how much pain I'm anticipating. Intraoperatively, I only use narcotics for induction, and I use a very small dose of fentanyl for induction. I have done a series of patients where I have not used even fentanyl for induction, and it has worked beautifully. So you really don't necessarily need to use narcotics even at induction, but if it makes you feel more comfortable, it's okay to use a smaller dose. So in patients who you don't want to use narcotics at all, I have used a bolus of dexmedetomidine, anywhere between 4 to 10 mics in small increments, combined with 2 milligrams per kilo of lidocaine and 0.2 milligrams per kilo of ketamine. The combination works extremely well for intubation, and it allows your patients to be hemodynamically stable. I have not seen a big sympathetic response at all to intubation when you use because they're already well analgesed with your oral multimodal analgesics that you've given preoperatively. And then you're adding, if you're not adding a small dose of fentanyl, you're adding 2 milligrams per kilo of lidocaine, dexmedetomidine, and ketamine, and that seems to be effective enough to allow you intubation without producing a sympathetic response. And then intraoperatively, I will either give ketamine boluses, and because these are short procedures, I don't think there's a big benefit in running in multiple infusions, but you can give lidocaine 1 to 2 milligrams per kilo every hour. So, or you can give half the dose every 30 minutes, which may simulate an infusion. But you can run either a ketamine infusion or give multiple doses of boluses of ketamine and dexmedetomidine as you please. This is extremely effective if you've added a TAP block to the whole scenario pre-operatively. So if the patients have a TAP block right after induction, and if the surgeons inject their laparoscopic ports right at induction, like before they start, this is a very effective regimen in either completely avoiding opioids or minimizing the opioids. And I always say that when you give narcotics to your patients, remember this. These are your patients. This is what their airway looks like. And you do not want to obtend them and make them lay flat in the immediate postoperative period, because even in the most challenging circumstances in the even in the most ideal circumstances in the operating room, these patients are most challenging to intubate. Now imagine them on the floor and they're receiving a 4 or 6 milligram dose of morphine or hydromorphone 1 milligram, and they are lying flat with no CPAP or BiPAP, and then you're suddenly asked to resuscitate that patient. You're not going to be able to get the airway effectively in that patient in a much shorter amount of time than you would have had on the operating room table. So whenever you give opioids to your patients, remember that this is what their airway looks like. Many of them have a neck circumference of more than 60 centimeters. So previously, while the analgesia used to have opioids, hypnosis, and relaxation, then regional anesthesia became a smaller aspect. Now, what we want to do is we want to make regional a bigger component of their pain relief, reduce the opioid component, and one day we want that opioids to completely disappear and let the regional and the co-analgesics take over the entire protocol. And so the new way is that use your foundational analgesics as the Tylenol, the NSAIDs, and regional anesthesia. You may add lidocaine. I used to use a lot of magnesium until I came to a new institution where they use methocarbamol or Robaxin instead of magnesium. But magnesium is a good NMD antagonist. I love magnesium. A single dose of 1 to 2 grams in patients with morbid obesity, it would even reduce the amount of neuromuscular blockade you need to give, because magnesium is a good muscle relaxant. Yes, sir? I give it at the beginning after induction. And I only give it as a single dose. I mean, there are studies that for infusions, but I just give it as because these are short procedures. And then ketamine and dexmedetomidine added to this whole thing will minimize the amount of opioids you need to give to these patients. And TAP blocks this is in a patient with morbid obesity. You may get a pretty good picture. The adipose tissue component may get bigger with bigger BMIs, but really, if you can get this done before the surgical incision, that will really help you a lot in minimizing the overall opioid requirements. And thank you, and we will have some time for discussion. I'll be happy to answer any questions.
Our next speaker is Dr. Fallon No, who is also a colleague of mine, a wonderful colleague of mine. She's an assistant professor in the Department of Anesthesiology and Pain Management at UT Southwestern Medical Center. She specializes in pain management, preoperative echo, and treating patients with cardiac disease. Dr. Fallon No completed her residency in anesthesiology and her fellowship in cardiac anesthesiology at the Cleveland Clinic Foundation. She then joined UT Southwestern as a faculty in 2014. Today she's going to talk to us about ERAS and peritoneal abdominal HIPEC management. Thank you so much, Dr. Fallon No. Please help me welcome her.
Thank you, Dr. Darwish, for this nice welcome, and this is my first time here at the meeting. Thank you for inviting me to give this talk. Today we'll be talking about abdominal and peritoneal hyperthermic intraperitoneal chemotherapy, or short HIPEC, and it's the enhanced recovery updates pertaining to it. I have no disclosures. So today's objectives: describe the anesthetic challenges of abdominal and peritoneal HIPEC surgery, and discuss the current anesthetic management updates in relation to enhanced recovery programs, and finally discuss the occupational safety concerns for operating room personnel. So what is the origin of HIPEC surgery? Well, the concept of cancer debulking was initially introduced in the 1930s for ovarian cancers. And by the 1970s, literature begins emerging, introducing the benefits of heated intraperitoneal chemotherapy. And it wasn't until 1990s that Paul Sugarbaker from the Washington Cancer Institute, Washington, D.C., first reported in literature the combined cytoreductive surgery with HIPEC. He described the stepwise approach to his cytoreductive surgery and began standardizing the procedure. And by today, it is now a well-established treatment for peritoneal cancer originating from colon, ovarian, appendix, and rectal metastases. The procedure has a pretty high morbidity, between 12 to 65%, but the mortality is compared to other surgical oncology procedures such as Whipple's and hepatotectomies. So there's 3 stages in HIPEC. There's a cytoreductive surgery stage and the debulking stage. The second stage is actually the administration of the chemotherapy intraoperatively into the patient's peritoneum. The third stage is GI reconstruction, usually finalizing any anastomoses, and then eventually closure of the abdomen. So the goal of cytoreductive surgery in the first stage is to remove all cancer involved in the peritoneum and viscera. But even with optimal macroscopic removal, microscopic disease will still remain, and it's this residual disease that we're targeting for treatment with intraoperative chemotherapy. And cytoreductive surgery, the first stage, can involve removal of multi-part organs, hemicolon, spleen, gallbladder, part of your peritoneum, partial liver resections, your uterus and ovaries. So it's a large surgery. And so the part of the actual administration of the chemotherapy, the goal of HIPEC is to maximize the local tissue exposure to high concentrations of chemotherapy. It's usually between 20 to 1,000 times greater than your plasma level administration. And the whole goal is just to minimize the effects on other local tissues. One advantage is that it does not depend on local blood supply to carry this chemo to your targeted area. The most commonly used chemotherapy drug is mitomycin C, followed by cisplatin, carboplatin. And we know these cancer cells are sensitive to heat between 40 to 43 degrees Celsius. The heat actually potentiates the medication and increases penetration into tumor tissue and reduces the tumor resistance. So there's 2 methods of administering the chemotherapy. There's the closed technique. In the closed technique, there's 1 inflow and 2 outflow cannulas. And the abdomen is actually closed, and then there is a roller pump that delivers and removes the chemotherapy from the patient. And the benefit is minimal heat loss while the abdomen's closed and minimal physical contact with the actual drug by the surgeon. There's some disadvantages. The closed technique has a lack of uniform chemo distribution and results usually in a higher intra-abdominal pressure because of all this additional perfusate, and could potentially reduce your preload and contribute to further hypotension in your case. The open technique, the abdomen is left open. There is 1 inflow and 4 suction drains. But the surgeon is constantly stirring the chemotherapy in the peritoneum, and it allows for adequate distribution of the medication to the abdominal cavity. So this is what it actually looks like in the operating room. Let's see. And where's this place? Oh, hold on. Back. So in this corner picture off to the left, there's a cannula. There's a single-use cannula and There we go. And a canister that contains the chemotherapy medication, the reservoir. It's heated in this machine, it's exchanged, and then I think it's going automated forward. And so what it actually set up looks like completely is there's a nurse who is monitoring temperature, monitoring the perfusate, recording temperature, and there's a surgical team member in the background agitating the abdomen back and forth so that the peritoneum is in constant contact with the chemotherapy drug. And they do this for about 90 minutes. And so the actual fluid, the chemotherapy, is maintained between 41 to 43 degrees Celsius. Currently, there's no evidence to support one method, closed or open, in terms of patient outcomes, morbidity, or surgical staff safety. So what are the operative aims of cytoreductive surgery and HIPEC surgery? To improve the survival of these patients with colorectal, appendiceal, ovarian, and mesothelial peritoneal cancer. And the outcomes are synergistic when you have combined cytoreductive surgery with HIPEC versus just cytoreductive surgery alone. And this is an example of survival outcomes for appendiceal cancer with peritoneal metastasis. The 5-year survival rate for either situation, cytoreductive surgery or combined, is anywhere between 24 to 57%. With cytoreductive surgery alone, it's 46.2%, and when you have combined cytoreductive surgery with HIPEC, your survival rate increases to 57.8%, which was considered a significant improvement. What are some of our challenges? Challenges can be divided into our phases of care: preoperative, intraoperative, postoperative. Our preoperative patients, typically, for example, a pseudomyxoma patient can develop large amounts of mucin deposits, causing a large volume of ascites. In addition to the ascites, they're usually malnourished from early satiety. They're an aspiration risk to us also. And they're usually coming to us, usually anemic, either from chronic disease or recent IV chemotherapy-related treatment. Intraoperatively, hypothermia due to large debulking and large area of just surface exposure during the debulking, large loss of acidic fluid, and potentially blood loss when they have to do a hepatic resection, all contribute to hypothermia. Coagulopathy is multifactorial. If they're coming to us prior with chemotherapy-induced coagulopathy, such as low platelet counts, nutritional deficiency, and contributed by us, dilutional coagulopathy. So postoperatively, the most common issue is acute kidney injury. It can result from hypotension, chemotherapy administration, and the EBL. And not mentioned on this list, it's not exhaustive, is actually pain management. Patients who are not candidates for an epidural, we have a challenging time managing their pain issues. Hyperthermia. So what we're doing is heating and administering a pretty hot chemotherapy to this patient, but we're also wanting to keep the patient's core body temperature below 39 degrees Celsius. Once you reach a core temperature greater than 40, you'll see the increased heart rate, metabolic rate, end-tidal CO2, metabolic acidosis, increased CVP and cardiac index. And then at the same time, you'll see peripheral vasodilation, which we have a challenging time treating. And so we're aiming to keep core temperatures below 39 degrees Celsius using ice packs, cooling mattresses, and turning off any fluid warmers that to keep the core temperatures below 39. What other challenges are we facing? A large inflammatory response after the administration of the chemo, and then this hyperdynamic circulation, usually from the debulking phase, losing the fluid and the blood earlier. Fluid management, there's a sizable amount of literature dedicated to HIPEC fluid management, and it is the most common question: how much fluid is adequate for these type of surgeries? The answer to the question is going to be case specific. There's a large variation in fluid requirements. due to fluid shifts depending on the tumor type, the extent of the disease, the duration of the surgery, and reported in the literature, it's anywhere from 5 to 24 mLs per kilo per hour. But overall, each case will receive some combination of crystalloid, albumin, blood, and potentially vasopressor. Most literature advocates for goal-directed fluid therapy to ensure adequate preload, organ perfusion, and avoid overload. And we do know that in literature that liberal fluid administration in HIPEC has serious consequences, tissue edema, delayed extubation, delayed feeding, and dilutional coagulopathy. So what makes HIPEC challenging is even with goal-directed fluid therapy, there's still this large variation in fluid requirement. But it is evident that goal-directed fluid therapy will decrease post-op morbidity. So in addition, we do know having a thoracic epidural in these cases is key to reducing morbidity. It reduces opioid consumption, the incidence of ileus, and promotes participation in physical therapy early in the recovery phase. It's also the key to extubation and reducing pulmonary complications with atelectasis and pneumonia. So acute kidney injury is another post-operative issue that we have a difficult time handling after these surgeries. The reported incidence is anywhere from 21 to 48%. The factors that we've identified from literature include being age over 50, obesity with a BMI over greater than 30, platinum-based chemotherapy agents, and lastly, blood loss. Inciting events, arterial hypotension, blood fluid redistribution, this exaggerated inflammatory response from the chemotherapy. And so what are some preventative measures? Preoperatively, they may receive renal stents. We're maintaining urine output as a surrogate for renal perfusion, anywhere between 1 to 2 mLs per kilo per hour during the case. So post-operative management, we aim to extubate these patients at the end of surgery if possible. Other issues post-operatively, continued use of the vasopressors, continued resuscitation in the ICU, monitoring for bleeding and coagulopathy. Venous thromboembolism is a large issue for these patients, and early enteral feeding to prevent gut bacterial translocation. However, even with these issues, the overall mortality rate for 30-day reported is from the National Surgical Quality Improvement Project database is only 1.1%. So enhanced recovery programs, what are its role into HIPEC surgery? To be honest, it hasn't demonstrated a difference in mortality, but it certainly has demonstrated a reduction in morbidity, such as acute renal injury, by using enhanced recovery programs. There's a survey from the American Society of Peritoneal Surface Malignancies found that 68% of 97 high-volume centers from 5 continents actually use a formal preoperative preparation pathway. So these are the most current guidelines from 2022. Actually, my co-panelist, Dr. Anu Wadhwa, is the co-author of this paper, and it's a set of guidelines for a very complex surgery and recommendations for all phases of care. But so in the early inception of HIPEC, peritoneal metastasis implied a poor prognosis and very limited treatment options. And it was usually, early clinical experience usually was associated with delayed feeding, usually from delayed extubation, liberal fluid administration. And with that experience, ERPs are emerging, and we're improving patient experience, decreasing their length of stay, decreasing their morbidity of acute kidney injury, and early participation of physical therapy. So what are the safety concerns for these types of cases? Chemotherapy exposure. And that's a concern for the anesthesiologist in the workplace, in addition to to the operating room personnel. Potential exposure routes are direct skin contact and inhalation of these aerosols. And one study examined the exposure of personal protective gear, or the effectiveness of personal protective gear. and tested that the permeability of these sterile surgical gloves and gowns. They found that mitomycin C levels were not found in the blood and urine samples from surgeons and the perfusionist. Another study looked at the aerosolization of cisplatin before, during, and after an open HIPEC procedure by analyzing air samples, and found that there's no air contamination in the air samples, but it found that most of the contamination was on the floor. So this overall surgery is demonstrated to be safe to patients and staff managing intraperitoneal chemotherapy, as long as they're maintaining personal protective equipment if you have close contact with the medication. So the use of double gloves, a level 4 fluid-resistant gown, and eye protection. Still, the long-term effects of low-dose occupational exposure is unknown, and literature does support limiting the exposure to pregnant nursing women or anyone who has a history of abortions, congenital malformations, and both men and women pursuing pregnancy. So future direction, there's still going to be an increased use of non-invasive blood pressure guidance, and then the continued evolution of enhanced recovery protocols for these types of surgeries. Conclusion, we know that cytoreductive surgery in HIPEC is associated with increased morbidity. There's a fluid administration is highly variable and needs are unique to the case. An AKI is a frequent complication after cytoreductive surgery with HIPEC, but the protocols are helping to reduce the incidence. And occupational health risk in HIPEC is limited to date, undetectable. However, we still don't know the long-term exposure effects. And that is the end of the presentation.
And now we're going to begin our panel discussion. If you have any questions for Dr. Wadhwa or Dr. No, please come up to the podium, and we have the microphones here. Do you have a question, Dr. Patrick? Please go ahead.
Thank you. Excellent presentations. Opioid-sparing analgesia and anesthesia. How do you prepare patients for this? I get a lot of communication from patients who maybe were not well informed that they would not be getting opioids or not a reduction in strategy. And just curious, do you do any special preparation before those surgeries and educate patients at that time?
That's a great question. I always make it a point of talking to them about it, and especially because we're giving them those oral pre-op medications, I take that as an opportunity to say we're giving you all these medications so that we can minimize narcotics, and the advantage of minimizing narcotics is that you have less post-operative nausea and vomiting, and you'll be less sleepy, so you can get up and walk. And part of your full recovery is that the earlier you walk, the better you're going to do. And I think all of these, talking about all this kind of hits them on the head. And they say, most of them will say, yes, I do not want narcotics. I have almost never had a patient who has said, no, I need opioids. They've either asked, like, will I have good pain relief? And I always tell them that there will never be a situation where you're in pain and you won't be rescued out of that pain. And at that point, if we have to give narcotics, we will give you, but you are going to need much smaller doses than you would have otherwise needed. And that usually works well in terms of counseling.
I can also comment to that. It helps also that both of us and even Dr. Darwish all participate in the pre-surgical testing clinic. So in that first instance when we meet the patient, we start talking about enhanced recovery programs at our institution and opioid-sparing modalities. And that's when you start to plant the seed. And then the day of surgery, the nurse talks to them about what medications they're receiving. And then finally, the day of surgery, anesthesia team will introduce, the epidural or regional block. And so when you slowly do it, I think in small doses, people are usually accepting of the plan.
Excellent, thank you. Dr. Jessica Galler, please go ahead.
Sorry,
Thank you.
I seem to like to ask lots of questions. So very, very interesting presentations about very, very pertinent issues that we're facing today. The first questions are for Dr. Wadhwa. Which element of the ERABS, I'll say, protocol, do you feel has had the greatest impact on early ambulation after bariatric surgery, knowing the vast importance of that element?
Sure. I think the two components are lack of pain and lack of nausea and vomiting, because if they are hurting really bad, they're not going to get out of bed and walk. Or if they are nauseous or actively throwing up, they're not going to. So those are the two main components that we can control. The other is lack of the nasogastric tube and abdominal drains. Again, that is extremely helpful. Also, preoperative counseling, just letting them know what the expectations are. That is extremely important. And if you've prepared them well and told them that you will be drinking within a couple of hours, and this didn't happen a couple of years ago, but now we've made so much progress that you will be actually drinking something and getting out of the bed on the same day. That mental preparation is extremely important, because they think that they're going to lay in bed for otherwise like for days. So that, I think for any ERAS protocol, that mental preparation that you're going to be getting up and walking the same day, because, and only then we'll send you home the next morning, is extremely important.
And that expectation, then they walk in knowing it's expected of them that they're going to do that, so that they don't come in with preconceived notions of that laying around.
Right. Even in HIPEC patients.
Go ahead.
So even in HIPEC patients, we set the expectations that you're going to be walking or doing some, or at least sitting in bed after post-op day one after this large surgery. Of course, with a regional anesthetic or pain control on board. So.
Given the conscious shift, especially with ERAS programs, of trying to go away from opioid monotherapy and extended opioid exposure, how soon after each of these types of surgeries are they able to be completely off of any opioid analgesics? We try in like posterior spinal fusions to have them off within 3 to 5 days max for that big procedure. How does it work with your particular ones?
You want to start first? Okay. So for bariatric procedures, because most of them are laparoscopic or robotic, we have seen patients who've not needed any opioids ever during their perioperative course. But for that, you and the surgeons have to be on the same team, which means that the surgeons have to continue the protocols even after, during admission and at home. And at UCSD, we had an amazing team, and we were all on the same page. And the surgeons continued the Tylenol, the Celebrex, and the pregabalin in small doses, because it does cause dizziness, for about 48 hours. And once the patients were ambulating, they really didn't need anything other than Tylenol and NSAID of some kind. So it is because for at least bariatric surgery procedures, it's very, very possible to have them and have them completely opioid free. But I think the tone needs to be set before the incision. So we have to bring the component of preventive analgesia into play, which means that we've actually saturated them with with the coxibs and NSAIDs, and then before the first incision, we've given them the ketamine and the dexamethasone. So we've covered the alpha-2 receptors as well as the NMDA receptor, and then if they've had a block. So when you have all of these components working together, essentially the central component of the brain doesn't even know that they had incision, which reduces the pain over a longer period of time.
It's a good way to prevent hyperalgesia from...
Exactly.
Do you see the same thing in HIPEC?
It's a very similar preoperative plan, introducing the concept very early by the surgeon and the anesthesiologist before we start the surgery. Since HIPEC is a little bit more extensive in an open surgery, they get an epidural for at least probably maybe 5 days until they can transition fully to an oral pain regimen. But we're still using preoperative non-opioid analgesics this entire time. And the surgeon is on board with us to continue this even when their patient's discharged from the hospital. And so I would say probably maybe a week, and then they get transitioned. Yeah.
What local mixture do you use in your epidural?
Actually, the interesting part of HIPEC is because they're so hemodynamically varying and sometimes unstable, we don't use a local anesthetic. We actually use a morphine dose into the epidural for the at least first 24 hours. And then afterwards, we're using low-dose bupivacaine, about 0.625.
So you're running a morphine infusion epidurally, and then you convert that to a local mixture.
Local with usually Dilaudid or fentanyl. But so the first 24 hours, just morphine, 3 to 4 milligrams of morphine in the epidural. It keeps the patient hemodynamically stable. We're extubating these patients at the end of this large multi-organ removal surgery. And then the ICU team understands to not administer a bolus of the epidural locally anesthetic until the next day.
That's got to be far superior to using a PCA.
Oh, yes, definitely.
Though lately I have been, for a few HIPEC patients, I have been using them intraoperatively, and so we give them a 100 mic fentanyl bolus right before incision, and we give them 50 mics of fentanyl every hour. And if they are stable, I have used 0.0625% bupivacaine intraoperatively also. The way I look at, and of course our philosophies are going to be very different because of the generation gap, but I believe that we can really treat hypotension. We are anesthesiologists. We shouldn't not give a patient local anesthetic intraoperatively because of hypotension. We are the experts in treating hypotension. So it's okay to run a low-dose phenylephrine infusion and make sure that you run an opioid-free anesthetic intraoperatively. And I have done that in several patients, and it has worked very effectively. And we've extubated the patients at the end and kept on running the epidural infusion.
That is fantastic. So in that realm, you don't need to keep a Foley catheter then when you have a thoracic epidural.
Absolutely, exactly, because you have a T6-7 epidural. Their sacral segments and lower lumbar segments are completely spared, and they do not need a Foley catheter.
Awesome.
Thank you so much. I have a question for Dr. Wadhwa, a little change of gear on pain management. Can you actually talk about obesity hypoventilation syndrome and specifically management intraoperatively and postoperatively, including in the ICU? What are your recommendations on that?
Sure, thank you. Those are the most challenging patients for bariatric surgery. So obesity hypoventilation syndrome is the extreme component of OSA, where the patients are hypoxic on room air, they are hypercapnic on room air, and it can only be diagnosed with ABG, where their PaCO2 is going to be above 45. And mostly it's 50 to 55. And the way we can maybe get an inclination that your patients may have OHS is if your bicarb on your regular lab is more than 27. So the chronic hypercapnia essentially compensates by metabolic alkalosis, and it takes the kidneys more than 48 hours to compensate for their respiratory acidosis by creating a metabolically alkalotic environment. So when you see a bicarb of more than 27, it means it's not acute hypercapnia, it is chronic hypercapnia. And the way to treat these patients, I feel, is that they will desaturate very, very quickly because they have very low reserves. So every aspect of intubation, supplementation you can get to prolong that apnea time should be used. These are the patients you want to bring that high ox cannula in and run them at 30 liters per minute while you're trying to intubate because they will desaturate very rapidly. These are the patients you want to have sitting up at extubation. You never want to extubate them deep or so fully awake sitting up and extubate to CPAP or BiPAP and continue that CPAP or BiPAP post-operatively. They are the patients who may need to remain intubated. I feel one of the major extubation criteria should be, so many times if we don't know what their baseline PaCO2 is, and if we see a PaCO2 of 55, we would maybe worried, like, can I extubate this patient at a PaCO2 of 55? So it's really important to do that baseline ABG in those patients to know what their baseline is so that you know okay, I can extubate this patient at a PaCO2 of 55. So these are challenging, but sometimes if their PaCO2 is 80, then you may have to take this. So these are the patients who may stay intubated for a day or so until all the anesthetic effect has worn off. So one of the other things, so these are generally the patients who are difficult to intubate and difficult to extubate. So I would use, one of those bougies that you can keep in place after extubation that you can quickly intubate the patients with. So if they were really difficult to intubate, I would keep that bougie in the mouth. And they are usually pretty easy to tolerate, so that in the ICU, if they need to be quickly intubated, then you have a conduit already present to put the tube in.
Do you see a utility in using Precedex on these patients while extubating them? And do you think that is helpful? Sometimes we like to do that in these kind of patients, obviously with the, like you said, the bougie and everything. And maybe also pain management is going to be even more difficult in these patients because they're going to be very sensitive to opioids.
My personal preference is ketamine rather than dexmedetomidine.
Okay.
So if I have to use an alternative infusion, I go for ketamine, only because if you look at a very recent study in anesthesiology, dexmedetomidine does affect the upper airway. Ever so slightly, but it does. Not as much as propofol does, but and these are patients who are exquisitely sensitive to the sedative effects of anything, narcotics. So I feel ketamine has a better upper airway profile in terms of maintenance of upper airway. So if I need help with pain management, I would run a 0.2 milligrams per kilo per hour infusion of ketamine. And maybe have the regional team do a second block at 24 hours, Okay.
Would you continue the ketamine afterwards, or what, is there anything you recommend?
For as long as you need it, yeah. I mean, personally, if you use that multimodal analgesic therapy along with a TAB block preoperatively, they may be okay with the non-steroidal therapy that you use for other patients. That was a great question. Thank you.
Thank you so much. Thank you. Dr. No, if I can ask you, can you describe at your institution how as far as your HIPIC ERAS protocol, especially pre-op, but also intra-op and post-op, like how do you guys specifically, what is specific to your institution, and also what have you found to be the most helpful strategy as far as, all the medications we use to help with pain management in these patients?
Part of our ERAS program begins initially with when we meet our patient in the preoperative clinic. Unfortunately, all of our anesthesiologists rotate in staff. So we are all part of introducing ERAS to our patients, and that's where we start describing their program to them, their pain management, and we set expectations for them, and that's probably the key. The expectation that you're going to be ambulating early, the expectation you're going to be receiving regional anesthesia, the expectation that we want you to stop smoking, and then also to see sometimes a nutritionist to optimize their nutritional deficiency if you're a cancer patient. The second part is the surgeon buy-in, that we were able to convince our surgeons that this is important to their patients and their outcomes. And so the surgeon follows along with what we recommend for pain management and preoperative optimization. And the third component is also getting our regional team to help us with the blocks and the follow-up. And as Anu and I both mentioned, for the first 24 hours, we're limiting the epidural sometimes to opioids. And if the patient can tolerate it, we'll either use local anesthetic or use a infusion for vasopressors so that they are comfortable and extubatable mostly at the end of surgery. Anu, do you have any comments?
Excellent, thank you. Also, a question for the both of you. Anything in the future in the works for HIPIC and bariatric patients? Any research that we're working on? Anything to expect hopefully in the near future that you want to, keep us in suspense for?
Do you have anything?
well, actually, both of us are part of the multi-site feasibility study of this ERAS protocol. So the main principal investigator is in France, and San Diego, I think Chicago, and UT Southwestern is a part of a multi-site study to see if, for evidence-based outcomes of this 2020 guidelines. So.
With pediatrics, I think the big movement that we are going to see is ambulatory procedures, really, that, surgeons are very keen. They want to, develop the guidelines to send the patients home the same day. So, of course, there'll be a careful selection of patients required for that, but that's the biggest thing we're going to see. And in terms of PUND, I think there's a brand new drug on the market for rescue. Do you remember the name of that medication? I think you presented at the other meeting.
Oh, for post-op nausea vomiting. It's an IV rescue medication. I want to say Yes, it's a dopamine antagonist that was an antipsychotic used in the early 90s in Europe. It slipped my mind. I think I want to say...
It slipped my mind too.
It starts with an A. Yes. Say it again. Yes, amisulpride, correct. That is emerging medication for rescue in PACU.
Because PUNV is such a big deal in these patients, and that's what prevents them from going home, I think, having another drug in the armamentarium is going to help with that.
Excellent. Dr. Fabra, hello.
Hi, I'm Mike from University of Miami. I had a question about, these more complex cases with all this fluid shifting and hemodynamic changes. What your thoughts are on some of this technology that's out there, this non-invasive stuff like ClearSight, hypoperfusion predictors. Are you using any of it? Do you think there's a role for it?
I think there's definitely a role for it, and we're definitely trialing different devices at our institution. Still, definitely the patient needs at base an A line plus or minus the central line, and we're basing these new devices on, data extracted from the A line and central line. We're trialing it. It's not perfect. You still have to use, baseline clinical judgment. And what do you think?
Yeah, I think goal-directed fluid therapy is huge for HIPEC. So I would definitely have not just an A line, but the flow track, really. And we have it in almost every patient. Having that hypotension prediction index is definitely useful. Personally, I think our brains should already be geared towards the science that monitor provides, and it's maybe more of a marketing gimmick, but remains to be seen. I think our institution is looking at the hypotension prediction index use in reducing outcomes in terms of acute kidney injury. I think there is a study going on, and we are one of the sites. Now, if that is the case, then maybe adding those monitors will maybe of extra help. But personally, I think all patients should get goal-directed fluid therapy who undergo HIPEC. Having a CVP monitor may be extra beneficial, but most cases we don't put one unless the patient has indications for so.
Hi, Suzanne Huffnagel, Jefferson Hospital in Philadelphia. Comment and a question for Dr. No. Thank you for mentioning that you have to pick the personnel in a HIPEC and avoid certain people. And we do HIPEC at my institution. I'm not on the team, but I honestly don't know if they're looking at that, and I'm going to find out when I go back. My question is, it uses so much resources and everything. I was wondering if the procedure is covered by insurance or if a lot of that cost has to be absorbed by the patient.
As far as I understand, I haven't heard of it not being covered by insurance from our surgeon. Yes, it is a costly procedure and resource intensive because we're using multiple nurses intraoperatively. What are your thoughts, Sonny, about coverage of what? Is it covered by insurance? What is the HIPEC surgery?
HIPEC is covered.
It is covered, yeah, 100%.
Yeah. It's very expensive surgery.
But
the surgeon has to, it has to qualify, and they have to, indicate the utility. And you're absolutely right. Some patients that we do, you're worried that do they really qualify? Are they really going to, do well with it, and it's hard to predict, but it's the surgeon who makes the call ultimately.
It's definitely a palliative surgery, and the life that they get is another, sometimes 5 years, which is a long time. If you have young kids, we have 40-year-olds with young kids, and 5 years, from the age of my daughter's 3, 8, that's a big change.
Yeah.
And it's growing a lot, and I don't know if anyone knows, but at Loma Linda, before I left, before I moved, they were doing intrathoracic HIPEC, not just intra-abdominal. They're actually doing now intrathoracic lung HIPECs.
Also pediatrics. I was reading that they're doing it to pediatric populations too.
It is advanced carcinomatosis, so I have never heard that it wouldn't be covered by insurance.
If we don't have any more questions, we will conclude this session. Thank you so much for joining us. Please help me welcome Dr. Anupa Wadhwa and Dr. Fallon No. Thank you so much, guys. I appreciate it. Thank you.